Hello, welcome to module number 3. Here we're going to look at our junctional zones, our shoulder and our upper arm. This is the ongoing training in the Haynes method of neuromuscular dry needling. Here we have the hybrid dry needling certification series, with lecture being online, on demand, and virtual, and at times live. And we follow that up with our in-person lab sessions for those who wish to achieve the certification. What we'll look at in lab module number 3, our live virtual module here, initially we're going to take a look at our surface anatomy and our three-dimensional anatomy. We'll later discuss our needle placement location. We'll look at a little bit of some supporting evidence. We'll talk about some clinical decision making, and then we'll go into our dry needling technique demonstration. In our junctional zone structures, we're going to look at our posterior scapulothoracic region here. We'll look at upper trapezius, latissimus, and then the multividus, spinalis, and longissimus there in the thoracic spine, as well as iliocostalis. On the anterior torso, we'll look at pectoralis major. We'll move into the pelvic rotator cuff here, Gluteus Maximus, Medius Minimus, and the tensor fascia lata, as well as piriformis, the Gemalis, obturators, and quadratus femoris. In our appendicular structures in the shoulder, we'll look at deltoid, infraspinatus, Teres Minor, and Teres Major. And then in the upper arm, the Coraco Brachialis, Biceps Brachii, the Brachialis, and the brachioradialis. At the end, there will be our standard post-module assignment for those who are looking for CEU credit and who would like to participate in the live lab sessions. So some supporting evidence here, for the shoulder. This is a study that was done in published in 2021 by Dunning et al. The title of it is Spinal Manipulation and Electrical Dry Needling in Patients with Subacromial Pain Syndrome, and it was a multi-center randomized clinical trial. We frequently talk about the use of dry needling as a modality, and it truly is that there's always going to need to be some sort of a manual therapy in place. There's always a movement dysfunction, and this study kind of brings that into play as well. Their objectives were to compare the effects of spinal thrust manipulation and electrical dry needling to those of non-thrust, peripheral joint soft tissue mobilization, exercise, and interferential current on pain and disability in patients with subacromial pain syndrome. The results here at 3 months, the thrust manipulation and electrical dry needling group experienced greater reductions in shoulder pain and disability compared to the non-thrust group. The effect size were large in favor of the thrust and dry needling group at 3 months. A greater proportion of patients within that thrust and dry needling group achieved a successful outcome, and they stopped taking medication. So the conclusion with this study was the cervical thoracic and upper rib thrust manipulation combined with electrical dry needling resulted in greater reductions in pain, disability, and medication intake than the non-thrust peripheral joint or soft tissue mobilization, exercise, and interferential current in patients with subacromial pain syndrome. And those effects were maintained at 3 months. Further down to the pelvic rotator cuff study by Brennan et al., dry needling versus cortisone injection in the treatment of greater trochanteric pain syndrome. This study was done and published in 2017. The objective was to investigate whether administration of dry needling is non-inferior to cortisone injection in reducing lateral hip pain and improving function in patients with greater trochanteric pain syndrome. The results of this study, the baseline characteristics were similar between groups. A non-inferiority test for repeated measures designed for pain and average function scores at 6 weeks indicated non-inferiority of dry needling versus cortisone injection. Medication usage was not different between groups at the same time point, and there were no adverse side effects reported. So the conclusion, cortisone injections for greater trochanteric pain syndrome did not provide greater pain relief or reduction in functional limitations than did dry needling. Their data suggests that dry needling is a non-inferior or an equal treatment alternative to cortisone injections in that patient population. So a couple of good studies, both in the shoulder and down into the pelvic rotator cuff. So some clinical decision making. We want to, again, look at our movement system abnormalities. For the posterior scapulothoracic region, we have to evaluate our scapula, our cervical and thoracic spine. We have to go out laterally, excuse me, and evaluate both the AC and then more medially at the SC joint, and then evaluate the shoulder as well. For our anterior torso, we need to be cognizant of the shoulder, the glenohumeral joint, both the AC and the SC joint, and then the sternocostal region. For our pelvic rotator cuff, we need to evaluate the system in both the lumbar, the sacroiliac, the pelvic, and the hip region. At the shoulder, we need to evaluate the cervical spine. We need to see evaluate that first rib. Again, the SC-AC joint, glenohumeral joint, and even further distally down to the elbow. In the upper arm, we have to look at the shoulder, the glenohumeral joint, anterior torso, and the elbow. And so I bring out this movement system abnormality issue. One of the challenges is, what is the problem? What is the dysfunction in this movement system that's creating the problem for the patient? Simply identifying where the pain is helpful, but we have to look both proximal and distal to evaluate if there's a movement system abnormality that's also impacting what's happening. In this, we want to assess our strength or our myotomes. We want to look at our range of motion. We want to look at our movement patterns. Are there any abnormalities? Is it symmetrical? And then for our pain pattern, is it focal? Is it localized? Or is there radiating symptoms elsewhere? We can break that down further. We will momentarily. Is that radiation because of entrapment or of a spinal origin? We want to definitely locate our points of tenderness. And then lastly, our altered sensation. Is it dermatomal, or is it more of a peripheral innervation or peripheral entrapment? With our clinical decision making on the posterior scapulothoracic region, here we want to start by evaluating our cervical and thoracic spine by doing our springing test. That'll help us determine if there is any sort of a discogenic problem involved there. We want to go through our palpation of our upper quadrant tenderness from C2 all the way down to T12. Here we're going to palpate our pair of vertebrals from our spinous process laterally past our iliocostalis. We want to evaluate our rhomboids, our trapezius, levator scap, our serratus anterior, and then our sets, supraspinatus, infraspinatus, teres minor, and subscap. Here we want to identify if there are any tender location, any bands or nodules. And we want to compare left versus right to see if there's any asymmetry with those locations. If there is a unilateral pain problem and we identify nodules bilaterally, then that may be just how they are. The question is how tender is the one on the symptomatic side. And then is this symptom that they're dealing with, is it aggravated through active, passive, or resistive movement? In our anterior torso, for our assessment, we want to start with our costosternal springing. See if there's any sort of soft tissue issue that we're dealing with more centrally. Then we want to look at our clavicular and our sternal attachment of pec major. We want to evaluate our pectoral fibers from lateral to the breast, and then our posterior and our middle deltoid. We want to take that further distally down to the deltoid tubercle, which is often a location of pain, especially radiating from the supraspinatus, especially if there is some pathology at its insertion. And then short head versus the long head of the biceps brachii. Again, identify what's tender, compare left and right, and can we provoke those symptoms through different types of movement. In our pelvic rotator cuff, we'll start with our lumbar vertebral springing. Again, let's identify whether this is a discogenic issue, and then palpation of our lumbar tenderness from T12 down to S2. Here again, the pair of vertebrals from the spinous process laterally past the iliocostalis. We'll also want to evaluate our palpation on the iliac crest, the PSIS, and the sacroiliac sulcus between the PSIS and the sacrum itself, that valley right there. Ischial tuberosity proximal to the hamstrings, and the greater tuberosity distal and proximal up to the iliac crest. We want to look at or palpate superior to the iliac crest for the QL, and then evaluate palpation for the pelvic floor, which we will cover in greater detail in Module 16, the last module of this series. For our shoulder, our palpation exam will look at our cervical paravertebrals, our upper trap, and our first rib mobilization, the deltoid down to the deltoid tuberosity. Again, with the supraspinatus, frequently we see that radiation in a focal tender point there at its insertion. Want to palpate our supra and infraspinous fossas, the pec major and latissimus. Of importance is the coracoid. Several muscles attach to the coracoid, and differential diagnosis we'll need to look at, is it a problem there on the coracoid itself, or is it further laterally onto the insertion of drawing a blank, subscap. Okay, so also evaluate bicep, the short and the long head, follow their path as they bifurcate to either the coracoid or the glenoid attachment, and then the triceps, the long and the lateral head. In the upper arm, our palpation will start with the shoulder. We'll look at biceps and triceps, the brachialis, and then the lateral group are the forearm extensors, and the medial group are the forearm flexors. So our 3D anatomy, here we'll look at our junctional zone structures. We've already discussed what's going to be involved here. So we'll start in the posterior scapulothoracic, upper traps, the latissimus dorsi, the multifidus, and the spinalis, longissimus, and iliocostalis cervices. For our origin, insertion, innervation, and action of these muscles, for the upper trapezius, origin is the upper nuchal line, the external occipital protuberance, the medial margin of the ligamentum nuchae, the spinous process of C2 to T2, and the related supraspinous ligaments. It inserts into the superior edge of the crest of the spine of the scapula, the acromion, the posterior border of the lateral third of the clavicle. It's innervated. The motor part is the spinal part of the accessory nerve, and sensory is the anterior rami of C3 and C4. Its action, it is a powerful elevator of the scapula. It's a rotator of the scapula during abduction of the humerus above horizontal. Its middle fibers retract the scapula, and the lower fibers depress the scapula. The Latissimus Dorsi, its origin, the spinous processes of the lower six thoracic and all lumbar and sacral vertebra, the posterior part of the iliac crest. It inserts into the medial lip, the crest of the lesser tubercle, and the floor of the intertubercular groove of the humerus. It's innervated by the thoracodorsal nerve 6, 7, and 8, and its action is extension, adduction, and internal rotation of the humerus. For the multifidus and the rotatories, for the multifidus, the origin is the sacrum, the origin of the rectus spinae, the superior iliac spine, the mammillary processes of the lumbar vertebra, the transverse processes of the thoracic vertebra, the articular processes of the lower four cervical vertebra. It inserts into the base of the spinous processes of all vertebra from L5 up to C2. It's innervated by the medial branch of the posterior rami of the spinal nerves. In its action, it stabilizes the vertebra and local movements of the vertebral column. Global movements, contracts bilaterally to extend the vertebral column and contracts unilaterally to produce rotation in the opposite direction. For the rotatories, you can see them in the picture there to the left. They are more yellow and orange in color. Their origin, the upper and the back part of the transverse process. It inserts into the lower border and lateral surface of the lamina of the vertebra above. Innervation, the medial branch of the posterior rami of the spinal nerves. Their action, they stabilize the vertebra and local movements of the vertebral column. Global movements, they contract bilaterally to extend the vertebral column and unilaterally to produce rotation in the opposite direction. In the spinalis thoracis, its origin, the spinous processes of T11 to L3. It inserts into the spinous process of T2 to T8. It's innervated by the posterior rami of the spinal nerves, and its action extends and laterally flexes the trunk. For the Longissimus, its origin, the spinous processes of all lumbar vertebra, the dorsal surface of the sacrum, and the posterior end of the iliac crest. It inserts into the fibers travel superiorly along the back and insert into the transverse processes of all thoracic and lumbar vertebra, the dorsal aspects of the posterior ends of the shafts of all 12 ribs. It's innervated by the segmental dorsal rami, and its action, primary extensors of the vertebral column and head, acting bilaterally, they straighten the back, returning it upright from a flexed position. The Iliocostalis, its origin, the sacrum, the spinous processes of the lumbar and lower two thoracic vertebra, and their supraspinous ligaments, and the iliac crest. Its insertion is into the angles of the lower 6 or 7 ribs, also a segmental posterior rami innervation. In its action, also a primary extensor of the vertebral column and head, acting bilaterally. They straighten the back, returning it upright from a flexed position. So let's look at this 3D anatomy. This will be number 1. Oh, bear with me, that's the wrong one. There we go. So let's take a look at our three-dimensional anatomy in the posterior scapulothoracic region. The structures we'll look at are the trapezius, upper, middle, lower, latissimus, the multifidus, spinalis, and then the longissimus and iliocostalis. So let's start with the trapezius, both the lower, let me catch up, the lower, middle, and upper portions there. With the upper trapezius, the origin is going to be in the external occipital protuberance and the superior nuchal line of the occipital bone. And I don't have the nuchal. Nope, there's the nuchal ligament. It's also going to attach on the nuchal ligament, and it'll start with the spinous process of C7. As we move down with the middle and posterior fibers, will continue to attach to the spinous processes all the way down to T12. The insertion on the posterior aspect of the lateral 1/3 of the clavicle, let me get that rotated around. So all the way on lateral third of the clavicle, on the acromion itself, and come all the way down. It's going to ultimately attach down the spine of the scapula itself, the lateral half to third in the inferior fibers. Trapezius, any upper body dysfunction that we're dealing with, good odds we're going to have some sort of dysfunction with that, especially the upper trapezius fibers. More often than not, it happens right in the mid-belly between the superior nuchal line and the acromion, just a mid spot right about there. So we move on to the latissimus. On the latissimus, and let me zoom in a little bit here. For the origin of the latissimus, it's going to be the spinous process of T7 to T12 and then L1 down to L5. Actually, let me hide or fade the traps. So again, similar to the trapezius, really broad muscle. It also has an attachment, or the origin via the thoracolumbar fascia down low, and then the 9th to the 12th ribs, and then probably most specifically down the iliac crest in this area, right there before the fibers of longissimus go beneath it or anterior to it to prevent it from attaching to the sacrum. Its insertion is on the humerus, so we look at an anterior view, and as I rotate around, it's going to insert just medial to the intertubercular groove. So that's the groove where the long head of the bicep sits as it comes over the humeral head, heading toward its attachment over here on the glenoid. So really an anterior attachment there, resulting in a really strong internal rotation effect with that. So we'll move back to the posterior aspect and look at the muscle. Let's look at multividus first. In multividus, again, we've looked at this before, but the origin, the posterior superior iliac spine, the dorsal surface of the sacrum, and the longissimus is sitting on top of it, so you can't see that, but the dorsum of the sacrum, the mammillary processes in the lumbar spine, the transverse processes in the thoracic spine, and then the lateral articular processes of C4 through C7. Inserts into the spinous processes of the lumbar, thoracic, and cervical vertebra all the way up to C2. Again, as we talked before, it does not continue on to C1. And again, it is the prime stabilizer in the spine, cervical, thoracic, and lumbar. Then we'll move from multividus onto the spinalis. We have both the spinalis cervicis muscle and a thoracis. In the cervical spine, here our origin is the nuchal ligament and the spinous processes of C7 down to T2, so right through here. And then its insertion is into the spinous processes of C2, 3, and 4. So 2, 3, and 4. And again, action in all of the erector spinae group, their action is going to be extending and either laterally flexing or rotating, in this case the neck, at the cervical vertebral joints. We move further distally into the thoracic spine, and then we'll see the spinalis thoracis. So here, the origin, the spinous processes of T11 down to L3. It inserts in the spinous processes of T2 down to T8. And again, extends, laterally flexes the trunk. So I've specifically mentioned the spinalis. As we are dry needling into our target tissue, most of the time going to be multividus, we take that measurement that we talked about, 1 finger breadth lateral from the superolateral aspect of the spinous process. We're definitely going to go through spinalis as we're headed towards that laminar backdrop as we're trying to dry needle multividus. And so that's spinalis. Let's look next at longissimus. 3 distinct muscles with longissimus. The biggest is longissimus thoracis. I still refer to it as lumborum in the lumbar spine, but its origin, spinous process of L1 through L5, in the dorsal surface of the sacrum and a little bit over to the iliac crest. It inserts into the transverse process of the lumbar and the thoracic vertebra and the 2nd to the 12th ribs. As we start to get into the thoracic spine, you will start to see a little bit of a lateral migration away from midline of the longissimus thoracis. So we move a little bit more into the cervical region. Then we find 2 more smaller structures. One is the longissimus cervicis, because it attaches into the cervical spine, and medial to that is the longissimus capitis, because it's attaching to the skull. So the longissimus capitis, here the origin is the transverse process of C4 down to T4, and it inserts into the mastoid process, get a little closer view there, of the temporal bone. We look laterally at the longissimus cervicis. Here, its origin is going to be the transverse process of T1 to T6, and then inserts into the posterior tubercles of the transverse processes of C2 through C6. And so just lateral to the articular pillar. We will find when we get to the advanced cervical piece, we also have some correlation here with the scalenes, and this is where we start to look at using the lateral, the articular pillar, especially at a certain level, for dry needling a large number of these muscles all at one time, including some of the scalene. And so that's longissimus. Let's look lastly at Iliocostalis. We do have Iliocostalis Slumborum. Again, its origin is the iliac crest and the posterior lateral aspect of the sacrum. It inserts into the transverse processes of L1 through L4, and then the angles of the 5th to the 10th ribs. As we get to the 10th, 11th rib, we're going to see that iliocostalis move a little bit more lateral with respect to this paravertebral group. And partly that is because this is also the location where Iliocostalis thoracis originates and takes off between Iliocostalis Slumborum and Longissimus thoracis. Here, Iliocostalis thoracis, the origin is the angle of the 7th to the 12th ribs. It inserts into the angles of the 1st to the 6th ribs. So it is possible, and we will address this when we get to the needling of this. It is possible to needle into that angle. It is a much higher skilled needling concept, simply because of this danger zone of the intercostal space and the potential for entering the lung field. So there we have the posterior scapulothoracic 3D anatomy. Next, we'll look at the anterior torso.
All right. So, moving on, our surface anatomy, our palpation lab. We will, so in each video, I'm going to explain all of this in detail. So I'm not going to read all of this to you, as we're going to cover it in the video itself, but just so that you have all of this information on our palpation and how we go through this. And this will be available not only here, but also you'll see it in the slides available to you in the student portal. Similar, both for the spinous processes, then for the scapula, which gets a little bit more in depth. But let's move here to 1A.
All right, so the posterior scapulothoracic surface anatomy. Let's start first in finding T11, T12. Here, quite simply, we're going to find that bottom rib. We're going to follow it medially until we reach the spine. The spinous process cranial to rib is T11. The spinous process caudal is T12. So let's identify that. And I'm just going to palpate for the inner spinous space. And so here's the inferior aspect and the superior aspect. So here is 11, here is 12. Quite simply, we can now follow these ribs, these spinous processes, as we come more cranial. And in the thoracic spine, there can be quite a distance between. So rotated with the head, it's gonna, the spinous process will rotate as well. And there's one. So you can follow those processes all the way up to get up to T1. Okay, so let's then talk about some reference points, both at T1 and at T3, T4. Before we do that, let's outline the margin of the scapula. So we'll look at the inferior border first, and then we will follow the medial border of the scapula up. You want to get all the way to the superior border. Superior border dive is a little bit deeper, so a little bit more challenging to palpate there. But there we have coming up and over. Another area we want to look at is the upper, or the more cranial, the more caudal piece of the spine of the scapula as it dives into the root of the spine of the scapula. Okay, we can follow the upper on out. To the acromion itself. That's similar with the inferior border. So we talk about T1. The superior border of the superior angle of the scapula is basically going to sit, give or take, at the spinous process of T1. If we look at the root of the scapula, now this scapula is actually up just a little bit. However, it's going to sit between the spinous processes of T3 and T4. So that's a really nice way for us to locate that spinal level. If we drop down further, between T7, again, his scapula is sitting a little bit high, and I may have drawn it just a little high. It's basically going to correlate across in between spinous process of T7 and T8. So as we're palpating also, we come off of the spinous process, you can move laterally onto the transverse process, and then as you move out a little bit further onto the rib itself, you can actually locate the costotransverse joint, where the rib comes and starts its articulation with the transverse process. So when we start at T1, talking about transverse processes in relation to the spinous process. At T1-2, if your finger is on the spinous process of T2, then the transverse process is going to be 1 finger width cranial to that. So its transverse process is going to be sitting a little bit more superior. And that's for T1 and T2. If we're at T3, T4, then on that spinous process, now the transverse process is going to be 2 finger breadths above. And this all allows for the orientation of the spinous process in that particular vertebral segment. So we're at 1 finger breadth cranial, at 1 and 2, at 3 and 4, it's 2 finger breadths cranial, at 5 through 8, now we're up to 3 finger breadths cranial. At 9 and 10, we're back down to 2 finger breadths cranial. And then for 11 and 12, we're back to a single finger breadth cranial for the orientation of the transverse process to the spinous process.
All right, so the treatment protocols for the posterior scapulothoracic area. We'll look at the spinalis, rotatories, and the multifidus. These are basically impossible to separate and differentiate during treatment, so we treat them as a single unit. Here, be in the prone position. What we want to notice, again, similar to what we did in the cervical spine, I selected the spinous process of T7 to maximize our ability to target as much muscle as possible with as few needles as possible. Again, as we discussed, this multifidus treatment can move up and down the spine. What might change is whether our 1 finger breadth lateral will actually let us get into the spinalis as well. So our treatment will be at the spinous process of T7. That is the level of the inferior angle of the scapula. Will be 1 finger breadth lateral. We're going to needle from posterior to anterior down to the lamina with, again, a 15 to 20 degree medial and inferior angulation with the needle.
For the thoracic spinalis, the rotatories, and the multifidus, the patient's going to be in the prone position, Knee length is going to be 20 to 40 millimeters. Backdrop here is going to be the thoracic lamina. Precautions here, the lung field, the medial branch, the posterior ramus of T6 and T7, anterior ramus of T8, 8th posterior intercostal artery in the vein. We're going to palpate for the spinous process of T7 at the level of the inferior angle of the scapula. Needle placement is 1 finger breadth lateral from the spinous process. Angulation at 15 to 20 degrees caudal and medial.
This general location is probably the most superficial that we will see, possibly a little bit more superficial, a little bit higher at around 5, 6, but we get a little bit more shallow with our lamina here, so needle length can be adjusted as necessary. Again, as we get through into the lordosis of the lumbar spine and the cervical spine, that needle depth needs to be adjusted to allow for that. For the interspinalis, similar to what we did in the lumbar spine, here we're going to go between the spinous process of T7 and T8. Again, that can be done anywhere along the spine, and this is where we will do that. The only time we do a superior needle in and around the spine, and again, we're going to have a shortened needle, less than 20 millimeters. We will again take this time 15 to 20 degree anterior and a superior angulation, again with the caution for the depth less than 20 millimeters to avoid that spinal canal.
For the interspinalis, position is going to be prone again. Needle length is less than 20 millimeters. There is no backdrop here. We're going to palpate to find the interspinous space between T7 and T8. When dealing with the spine, this will be the only time that you will have a superior needle angulation. Here it's going to be 15 to 20 degrees anterior, superior, perpendicular to the skin surface. Again, caution for the depth, less than 20 millimeters to avoid the spinal canal.
All right, very simple. Okay, from there, move on to the Longissimus and the Iliocostalis. In this picture, you can see with our 1 finger breadth here in the thoracic spine, lateral from the spinous process, we are no longer going to be able to needle into Longissimus. So in the thoracic spine, Longissimus and Iliocostalis are needled together. For Longissimus and Iliocostalis will be 3 to 4 finger breadths lateral to the spinous process of T7. We're going to have a 50 to 60 degree medial and a 15 to 20 degree caudal angulation relative to that skin surface.
For the thoracic longissimus and iliocostalis, again, patient's going to be in the prone position. Needle length will be about 30 millimeters. There is no backdrop. We're going to grasp the lateral border of the rectus spinae group with a profundus grip. We're going to apply firm pressure, splay the index and middle finger. We're going to needle 3 to 4 finger breadths lateral to the spinous process of T7 with a 50 to 60 degree medial and a 15 to 20 degree caudal angulation in each plane perpendicular to the skin surface or relative orientation of the vertebral lamina with no backdrop.
So in this
video, you see for camera's purpose, I'm kneeling across the body and kneeling back towards me. But not only is it just good for the camera angle, when dealing with the spine, it's always preferable to stand on the opposite side that you're treating, so that you can direct that needle back toward you. You have a little bit better control of the needle that way in its application than if you were to try to needle on the same side and to try to pronate harder to get the needle in there. So always treat on the spine on the side opposite, or stand on the side opposite the side that you're treating. Okay, then to the Latissimus Dorsi, and I'll let the video speak for itself here. For the latissimus, the patient's going to be in the prone position. We're going to use a needle of 30 to 40 millimeters. Backdrop, there is none. We're going to grasp the muscle near the humerus, pulling it away from the body using the fingers to block the rib cage, palpating for the thickest part of the muscle. We're going to needle posterior to anterior, medial to lateral, parallel with the rib cage, using the fingers to determine appropriate depth. So this is another one of those issues. Whenever you place the needle into the skin and advance it, you will feel that needle begin to approximate your fingers. The skin is tough, so unless you're just not paying attention, or if you don't have your hands properly placed, you will feel that needle approximate, so that you don't exit through the skin on the other side. But that's the dry needling approach for latissimus. For the upper trapezius, biggest issue here is we want to make sure that we stay away from the lung field. There's many ways to dry needle the latissimus here. I'm sorry, the upper traps here. There are, according to Travell, there's more than one trigger point in here, and every individual seems to have a little bit different best location, if you will. Biggest thing, we want to make sure that we stay 1 thumb breadth above the supraclavicular margin. That way we avoid the apex of the lung and that neurovascular bundle that sits inside that supraclavicular triangle. For the upper trapezius, the patient again is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. There is no backdrop. We're going to palpate for the thickest aspect of the muscle belly. We're going to grasp the muscle between the thumb posteriorly and the fingers anteriorly, at least 1 thumb breadth above the supraclavicular margin to avoid the apex of the lung. We're going to insert the needle into the muscle in a posterior to anterior trajectory, using the fingers opposite the insertion point as a guide to determine needle depth. Again, when dealing with the upper traps, you can usually palpate, squeeze along the line of that trap to find the most tender aspect, or the most bulky aspect of that muscle, and that's usually the best location for placement of the needle. When coming from the posterior aspect, you want to make sure that you advance the needle from inferior to superior to assist in avoiding that triangle on the front side, so to stay out of the neurovascular bundle and the lung field. Frequently get very good response out of this. First time I treat a person, if possible, want them to be prone. It can also be done in the supine position, but you want them down. A lot of people can have some fairly strong reactions to this. Probably one of the more, if you exclude the hands and the feet, this muscle is probably one that tends to elicit more of the dizziness, the cold sweats than any of the others, because it's just a strong release. So for our posterior scapula thoracic region, basically this is everything that we needled out to the laterally. Hit the lats, you see the upper trap superiorly, Longissimus, Iliocostalis, and then Multividus, Spinalis, and Rotatories here at T7. Moving to the anterior torso for the pectoralis major, its origin is the medial 2/3 of the clavicle, the sternum, and the costal cartilages 1 through 6. It inserts into the lateral lip of the intertubercular groove, the crest of the greater tubercle of the humerus. It's innervated, the lateral pectoral is by the upper pectoralis nerve C5, 6, and 7, and then the medial pectoral by the lower pectoral nerve C8 and T1. Its action, adduction and medial rotation of the arm, flexion of the clavicular fibers, and extension the sternocostal fibers of the humerus. So let's go to our 3D anatomy.
Let's move on to the three-dimensional anatomy of the anterior torso. Here we're going to limit ourselves to the view of pectoralis major. So pec major, the origin, anterior aspects of the medial half of the clavicle. To get a view right there. Medial half of the clavicle, down on the manubrium and the body of the sternum. Change my angle a little bit there. And the superior 6 costal cartilage. The aponeurosis of the external oblique, abdominal oblique as well. And so we've got a fairly large location there. Interesting, I'm going to come up and pull up just so that we have a frame of reference here. Let me make this happen. So let's look at the left trapezius. So we've got a really close approximation of the insertion. So the upper trapezius on the clavicle attaches on the posterior aspect, while pec major attaches on the proximal third half of the clavicle on the anterior inferior surface. So some really big, powerful movers attaching onto that structure. Its insertion is the posterior, wrong muscle, let's get the pec. Insertion, the crest of the greater tubercle of the humerus. So I want to move over to, well, one thing that's very interesting with pec is the wrapping and the orientation of the fibers themselves. We look at a posterior view, the inferior, the sternal muscle fibers, you can see cross and come more, let me get rid of that, have a more superior orientation onto the insertion, whereas the superior fibers, or the clavicular portion, comes down, wrapping around a little bit more down to the inferior aspect, and then the middle fibers just coming basically straight across, medial to lateral. But I want to look on the model here on the right side to look at the orientation and the workings of pec major, the long head of the bicep, and then latissimus. So we talked about latissimus, which sits right here, attaching to the medial aspect of that intertubercular groove for the biceps long head. Well, we then see the pec major just going just lateral to that intertubercular groove to attach onto that crest. So an interesting way to recognize the level of attachment of both of these muscle groups, or muscles, as they attach on the proximal humerus. So that's the pectoralis major and the anterior torso. Next, we'll move on to the pelvic rotator cuff.
Okay, before we go to the PRC, we'll go into our pectoralis major treatment. Here we're going to be in the supine position, as you're going to see. Almost the exact treatment approach as we did for latissimus. Teres Major. The patient is going to be in the supine position. Needle length will be from 40 to 60 millimeters based on patient's habitus. Backdrop, there's going to be no backdrop in this situation. Again, with the patient in the supine position, shoulder will be abducted to 90 degrees and then externally rotated. In that position, we're going to grasp the muscle with the fingers in the axilla, blocking the rib cage, palpating between the thumb to locate the thickest aspect of the muscle. We're going to pull the muscle away from the rib cage, and we're going to needle medial to lateral, parallel with the rib cage, using the fingers as a backdrop to determine appropriate depth. Caution here to avoid the lung field. Now we're going to move on to what's termed the pelvic rotator cuff. Here, glute max, med, and minimus, the TFL, piriformis, and then group together the hip rotators. We get to the pelvic floor. I'd break some of these out individually. Here in this approach, we're going to just treat them as a single unit. For gluteus maximus, we're going to cover this in detail in our 3D anatomy, so instead of me reading it here, we'll come back to glute max, med, min, the TFL, piriformis, the Gemalis, obturator, the quadratus femoris. So let's look at it in our 3D anatomy approach. Okay, so let's move into 3D anatomy of the pelvic rotator cuff. Here we'll look at the gluteus maximus, medius minimus, tensor fascia lata, piriformis, the superior and inferior gemalis, the obturator intertis and externus, and quadratus femoris. So let's start at the very most superficial with gluteus maximus. Close that, bring that up right there. All right, so gluteus maximus, the origin, the area of the ilium located posterior to its posterior gluteal line, the posterior aspects of the sacrum and the coccyx and the sacrotuberous ligament more deeply placed. It inserts into the tubercle of the iliotibial tract on the tibia via the iliotibial tract and the great gluteal tuberosity of the femur. Its action is extends laterally or externally, rotates, and abducts the thigh at the hip joint. So there is a location, we will get to this when we do dry needling, what I call a master point located right here. That is kind of the convergence of the upper or the outermost gluteus maximus. I'll hide that. And then medius, which we'll discuss next, and you can tell beneath that is minimus. So a really strong point for all that posterior hip musculature. So next we'll look at, let's go out of order here. Let's talk about TFL and the IT band. The tensor fascia lata, the origin is the anterior superior iliac spine and the anterior 1/3 of the outer lip of the iliac crest. It inserts into the tubercle of the iliotibial tract on the tibia via the iliotibial tract. In its action, it assists in medial rotation, abduction, and flexion of the thigh at the hip joint. All right, so, and whenever we palpate for this, and we'll talk about it in the palpation lab, the IT band or IT tract is very prominent on the lateral aspect, and we frequently use that as a landmark coming off the greater trochanter up to the iliac crest. But let's hide that and that, and let's get to gluteus medius and then minimus. So gluteus medius, it is the origin area of the ilium located between the anterior and posterior gluteal lines, which with the muscles removed, you can see the gluteal lines. It inserts into the lateral aspect of the greater trochanter of the femur. So one thing of note, gluteus medius is inserts a little bit, now the arm's in the way, a little bit on the posterior aspect of the trochanter, whereas Gluteus Minimus inserts a little more onto the anterior aspect. So you can consider a line between them with medius posterior and minimus anterior. But Gluteus Medius, let me bring that back up. Its action is medially rotating and abducting the thigh at the hip joint. And so we'll hide medius and get down to minimus. All right. Let me catch up here. So Gluteus Minimus, the origin area of the ilium located between the anterior and inferior gluteal lines. So here's the superior gluteal line and then the inferior, and that sits right at that inferior gluteal line. It inserts into the anterolateral aspect of the greater trochanter, and its action also medially rotation and abduction of the thigh at the hip joint. So we'll move down to the piriformis. The piriformis is the origin is on the pelvic or the anterior surface. If we look through the foramen, you can kind of see. Well, let's look at anteriorly. So piriformis, again, it has fibers that go around the sacral foramen, but it attaches very medially onto the sacrum. And then it inserts into the superior border of the greater trochanter of the femur. So when needling this, it's important to realize it's not out lateral, it's on the medial aspect. And so to properly needle it, you have to come a little bit more medial to get into the bulk of the muscle. Also to be cautious with the piriformis of the sciatic nerve exiting the sciatic foramen as it comes down and travels right through here. So its action is it laterally rotates and transversely abducts the thigh at the hip joint. We'll move inferior to that, and then we will see the superior gemalis inserts on the medial aspect. The origin is on the ischial spine of the pelvis, and then it inserts very, very similarly to the greater trochanter, just inferior to the piriformis. And its action is lateral rotation and transverse abduction of the thigh at the hip joint. We'll drop a little bit more to the external, the obturator intertis. So here at the obturator foramen, on the ramus, we can see, and I'm going to rotate a little bit here. We've got obturator externus and then obturator internis. For our purposes here, we're going to needle all of these, except the piriformis, all of these in a single needling redirection as we get more into the pelvic floor. Then we'll look at needling actually over into the muscle belly itself. But we'll try to just pick along the line of the neck of the femur to attack all of these muscles. But anyway, obturator internis, its origin, the internal surface of the obturator membrane and the adjacent bones. It inserts into the medial aspect of the greater trochanter, and its action is lateral rotation and transversely abducts the thigh at the hip joint. Again, let's move and look at externus, obturator externus. Here, the origin is the external surface of the obturator membrane. It inserts into the trochanteric fossa of the femur, and it laterally rotates the thigh at the hip joint. And so it is buried a little bit deep as far as its insertion. Let's see if we can trace it back. There we go. So just inferior and behind quadratus femoris. So next in line, we'll look at the inferior gemalis. Here, the origin is the superiormost aspect of the ischial tuberosity. It inserts into the medial aspect of the greater trochanter, and again, its action is lateral rotation and transversely abducts the thigh at the hip joint. And then lastly, down on the quadratus femoris, its origin is the lateral margin of the ischial tuberosity, and it inserts in the quadrate tubercle of the femur. Its action is lateral rotation of the thigh at the hip joint. And so those are the muscles of the pelvic rotator cuff. Next up, we'll take a look at the shoulder and then the upper arm.
But before we get to the shoulder and the upper arm, let's look at our surface anatomy. So again, this information is available to you both in the presentation but in the slides that are in the student portal. So I'm going to, instead of talking through this, let's just get down to the video itself. So surface anatomy of the pelvic rotator cuff. We'll start to identifying the iliac crest and the PSIS. So we can come down off of the 12th rib, come on down, locate iliac crest. So we want to draw that from lateral all the way over until we locate. It's going to angle down a little. And our target here is we want to find PSIS. You want to come down and you want to find the inferior most aspect as well. Okay, we'll do that on both sides as we're coming down. All right, very good. So there's the iliac crest and the PSIS. Now what we want to do is we're going to draw a helper's line from the inferior aspect of PSIS. And we do that because that's going to help us identify in midline S2. So the next thing we want to do is we're going to locate the sacral horns. From there, we're going to create a helper's line from the sacral horn to the PSIS. You want to advise, if you're going to draw on your patient, definitely advise them of what you're doing. Right there. So sacral horn, and for this point forward, I will just simply use one side here. So our next helper line will be from the PSIS down to the sacral horn. We also want to divide this helper's line into thirds. So we have a upper, middle, and lower third. So next what we want to do is draw another helper's line, and this one is going to be from the PSIS down to the ischial tuberosity. So we're just going to come in, palpate, locate that ischial tuberosity, and it's pretty well going to be in a nice straight line. So that's our ischial helper's line. Next, what we want to do is roll our greater troch, or roll our leg, so we can identify the superior most aspect of a greater trochanter. And then we'll draw that. Okay, so here we are with the greater troch. From there, we want to identify our piriformis. So piriformis, we're going to use two lines from this area. Our caudal border, or our inferior, will be from the PSIS to the sacral hiatus. And it's going to be the inferior line. So what that means is we're going to come from here to this line. If I can make that nice and straight. Okay. Our second will be to the line at the upper where the PSIS is. And so our same spot here, I will come to right there.
So here is piriformis, off the greater trochanter to the upper 2/3 of basically the sacral body. So we can also palpate for the superior gluteal nerve, and we can find that by splitting this upper line into thirds. And so superior gluteal nerve can be palpated at times at that mark right here. We can also look the inferior line. We can turn that into thirds as well, and we can use that to locate the inferior gluteal nerve. And that one's going to be midway between the marks. So here we'll have inferior gluteal nerve. If we wanted to trace the course of the sciatic nerve, it's going to come from the medial 1/3 mark of the piriformis to the halfway mark on the line from the ischial tuberosity to greater trochanter, and then straight inferior from that point. So we'll come from here out to our location here, and then completely inferior. And so that is sciatic nerve.
All right. So for our treatment, so a lot of your low back, a lot of your everyday garden variety patients that you see, this is going to be some bread and butter go-to treatment for these folks. And so let's just come back to it. First, for Glute Max, again, we identified the superior aspect of the greater troch and the PSIS, and we're simply going to find a midpoint between there. The nice thing is, and this is a nice little hot spot, is as we needle this, we're going to catch the Gluteus Maximus, we're going to catch glute med as well as we penetrate further, and then we're going to catch the posteriormost fibers of glute min as well. But here we're going to target it just for glute max.
For the Gluteus Maximus, the patient is going to be in the prone position. Needle length here will be 40 to 60 plus millimeters. The backdrop is going to be on the ilium. We're going to locate a midpoint between the PSIS and the superior aspect of the greater trochanter. We're going to needle posterior to anterior with relative orientation to the ilium. Use the ilium as a bony backdrop. Caution here for the sciatic nerve. Proper angulation of the needle perpendicular to the ilium will place the needle superior to the sciatic nerve.
Okay, then to Gluteus Medius. Again, prone position, we're going to follow, we're going to find the lateral aspect of the greater troch. We're going to follow that tendon of the TFL up to the iliac crest. We're going to move posteriorly 3 finger breadths, and then we're going to drop posteriorly again 2 to 3 finger breadths into the Gluteus Medius, and that will be our needle location. Truly anywhere in this area we'll get Gluteus Medius, but this is, if we want to separate glute med from glute max, this location lets us do that.
For the Gluteus Medius, the patient is going to be in the prone position. Needle length here is going to be 40 to 60 millimeters. The backdrop is going to be onto the ilium. We're going to palpate for the iliotibial band superior to the greater trochanter to the iliac crest. We're going to move 3 finger breadths posterior on the iliac crest, and then insert the needle 2 to 4 finger breadths inferior from the iliac crest into the muscle with an angulation into the muscle perpendicular to and using the ilium as a backdrop. Onto Gluteus Minimus, how we located the greater trochanter and have this line from that up to through the TFL up to the iliac crest. We're going to find a midpoint between iliac crest and greater troch, and we're simply going to use our needle down to the ilium again as our backdrop, and that lets us identify and target glute min. We will get some glute med fibers as well, absolutely. A little bit of some max as well, but that's what we're doing here for glute min. For the gluteus minimus, patient again is going to be in the prone position. Needle length is 40 to 60 millimeters, and the backdrop is going to be onto the iliofemoral ligament. We're going to palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. And we're going to insert a needle at a midpoint between the iliac crest and the trochanteric apex in a lateral to medial direction using the iliofemoral ligament as a backdrop. Then for the tensor fascia lata, again, we're going to be in the prone position. Again, we're starting everything in the prone position. Frequently, I do treat this in a side-lying position. Can be more comfortable for our more degenerative patients, but for our purposes here for training, we're going to do it in the prone position. So it can also be done in the supine position on this particular one. For the tensor fascia lata, or the TFL, patient again is in the prone position. Needle length here is 30 to 40 millimeters, and there's no backdrop. We'll palpate the apex of the greater trochanter and the iliac crest. We should palpate the IT band along this path. We'll grasp the anterior aspect of the TFL with the fingers and the posterior aspect of the IT band with the thumb. At the midpoint between the two bony landmarks, we'll insert a needle and advance posterior to anterior, medial to slightly lateral towards the table, using your fingers as a backdrop to determine adequate depth. In this treatment approach, it's important to realize that each body is going to have a different amount of adipose tissue, and if we want to make certain that we are entering into that TFL, we have to do a very good job with our palpation of where that tendon attaches onto the iliac crest, and make sure that our needle is in fact going through that muscle. And then to the piriformis. Here, so in this lecture, this module, what we're going to do is needle piriformis on a more lateral approach, just medial to the greater trochanter. As we get into the advanced lumbar module, we will needle it more in a medial area into more of the muscle bulk. As we just get started, we want to just focus on this lateral needle placement, however. We're going to talk in a little bit in this video about moving, so we find the apex of the trochanter. We're going to move up a finger breadth, and we're going to move medial 2 finger breadths. It's important to understand that that's medial in the frontal plane, as opposed to just 2 finger breadths along the curve of their anatomy. So you can move, if we have a person with a lot of adipose tissue, we could find that we move 2 finger breadths posteriorly as we're coming across the buttocks, but it has to be in towards midline. So relative to say the sacrum, we want that 2 finger breadths more medially that direction.
For the piriformis, the patient again will be in the prone position. Needle length can be 30 to 50 millimeters. The backdrop here will be the ischiofemoral ligament. For the lateral attachment, we'll palpate for the superior aspect of the greater trochanter and locate its medial most aspect. Needle insertion point is 2 finger breadths medial and 1 finger breadth superior, posterior to anterior, using the ischiofemoral ligament as a backdrop.
Again, in this case, we have to make certain that we move 2 finger breadths from the lateral apex of the greater trochanter and a frontal plane towards the sacrum in order to pierce into the piriformis. And then lastly, the superior gemalis, obturator internis, inferior gemalis, obturator externus, and quadratus femoris. For our purposes here, we're going to treat this as a single structure. We have what we're going to do is we're going to find that superior apex. We're going to move 2 finger breadths medially, very similar to what we did with piriformis. We're just not going to move up more cranial like we did with piriformis. So we're going to move over 2 finger breadths more medial, and then we're going to simply drop that needle. We're going to peck down that row of rotators to finally terminate into quadratus femoris.
For the superior gemalis, the obturator internis, inferior gemalis, obturator externus, and quadratus femoris. We're going to treat this as a single unit. We're going to be in the prone position. Needle length here could be 30 to 50 millimeters, and our backdrop is going to be onto the femoral neck. These muscles are most frequently needled as a group using a redirection method. We're going to palpate the superior aspect of the greater troch and then locate its medial most aspect. We're going to needle insertion point at 2 finger breadths medial and 1 finger breadth to 4 finger breadths inferior, PA, using the femoral neck as a backdrop.
So advance, then we're simply going to redirect. And we're going to redirect inferiorly to land into quadratus femoris. On to the appendicular regions. We'll start with the shoulder. Here we're going to look at the posterior delt, infraspinatus, Teres Minor, and Teres Major. Some complications with supraspinatus, so we're going to wait on that until we get into the advanced shoulder component. But for the deltoid, we're going to talk about our anatomy again using our 3D model. So I'm going to skip reading this to you. Deltoid, infraspinatus, Teres Minor, and Teres Major, and then let's look at it here. Where did she go? I have lost her. Nope, that's the wrong one. Bear with me. It's hidden from my view. me try that again. There we go. All right.
And the 3D anatomy of the shoulder, or the introductory shoulder muscles, will get much more in depth in the later aspects. You'll notice that the supraspinatus is is absent from this section, and quite honestly, at this point, we leave that off simply because of the potential risk for pneumothorax if we go a little bit too interior into this lung field. But we will get to that in the advanced shoulder. Here we'll look at the deltoid, infraspinatus, and then teres minor and major. So if we look at the deltoid, let me bring 3 different aspects of the deltoid: anterior, lateral, and posterior. You can see that the origin is going to be off the lateral third of the clavicle, then around the acromion, and then further back to almost all of the spine of the scapula. So it's got a very similar attachment to the upper trapezius. Matter of fact, let's bring that on. Let me close this, and let's add in that left trapezius just to see how that looks and what happened. There we go. So as we look at similar, we had the pec major with a very similar orientation right here. The pec major will line up very closely to the most medial aspect of anterior deltoid. The orientation or the attachment of upper trapezius and the deltoid also shares a very similar footprint. All right, so let me hide that. The deltoid itself inserts into about mid-shaft of the humerus into the deltoid tubercle. It's, let me bring that up, there we go. Where did we go? Its action is abduction of the arm at the glenohumeral joint. The anterior deltoid will also give a little flexion and medial rotation of the arm, whereas the posterior delt will also give us a little extension and then laterally rotation, and then also some transverse abduction at the glenohumeral joint. So deltoid there, complex muscle. Let's come to this side. I'm going to hide the deltoid here so that we can see infraspinatus, teres minor, and teres major. Infraspinatus, its origin is the infraspinous fossa of the scapula, so it takes up all of that territory, or most all of that territory below the spine of the scapula. It inserts into the greater tubercle of the humerus, and I'm gonna get rid of the bursa for a moment here. So on the superior aspect of the humerus itself, when we look at supraspinatus, we're going to see that it has a footprint on this superior facet of the greater tubercle, and then it also comes over and has some mixed fibers in with infraspinatus as well. So its footprint goes from about the edge, the lip of the groove laterally over the apex and then down just a little bit. With the infraspinatus, it is all on this posterior, this angled facet itself. The action is it laterally rotates and transversely abducts and stabilizes the arm at the glenohumeral joint. So the function of the rotator cuff itself can be considered the rotation, but on the true purpose of the rotator cuff is to provide stability of the glenoid in or the head of the humerus in the glenoid cavity itself. So infraspinatus will drop in to look at teres minor. Let me fade that. So teres minor, come out. So teres minor, its origin is the posterior aspect of the superior half of the lateral border of the scapula. So we split the scapula in half
in a superior to inferior aspect, and that's going to be the origin of the Teres Minor. It inserts into the greater tubercle of the humerus, and it will be at the inferior facet of this rotator cuff footprint. Its action is laterally rotating, transversely abducting, and stabilizing the arm at the glenohumeral joint. And then finally, Teres Major. Its origin, the posterior aspect of the inferior angle of the scapula. It inserts into the crest of the lesser tubercle of the humerus. So this we see a very similar attachment site. If we remember, Latissimus is also very close. So let me pull Latissimus back up just for your orientation. Latissimus Dorsi, right. So we see it, the Latissimus coming over, and it shares a very similar insertion as does Teres Major. Its action is adducts, medially rotates, and extends the arm at the glenohumeral joint. And that is our three-dimensional anatomy of the shoulder.
So for our surface anatomy, our palpation lab, again, same instructions. These are going to be available to you to review on the student portal as well as on our app. So we'll move down through these and get to the video. Okay, so some surface anatomy for the shoulder and in the upper arm. And especially this is relevant to this introductory level for our first lab session. So one of the first things we want to do, we had already marked and identified the spine of the scapula coming laterally, but we can continue to follow that acromion as it makes its way to the anterior aspect. So we can palpate that coming on around. So we want to know where that acromion is. Another structure we want to identify is the deltoid tubercle. So you can have your patient abduct out, ab away to identify the deltoid tubercle. And it's going to end up being, give or take, halfway, midway point between the elbow and the acromion. So we'll call this our deltoid tubercle. You can identify the muscles of the deltoid itself coming off the lateral half of the spine of the scapula, and it will traverse here. You can have them extend, and it'll go and extend backward, and you can see the fibers of deltoid there. Similar on the anterior deltoid with its fibers coming off the lateral third of the clavicle. Go ahead and flex, and then you can identify those fibers as they're coming down to their attachment here. So deltoid muscle here, we want to find the lateral epicondyle. And so we identify here. And then we want to follow that up on the supracondylar ridge. And we can follow that a fairly good distance, almost all the way to the deltoid tubercle. So a nice traveling spot right there. One thing that we can do, go ahead and flex the elbow, give me to 90, and hold the thumb there. We can identify brachioradialis as it's traveling over to the supracondylar ridge. And it will actually be about right here. Go ahead and let that relax. Now, very important to note, posterior to the supracondylar ridge, this is all tricep. Anterior, we're going to have a bifurcation or two separate muscles we want to talk about. One, obviously, the bicep. So go ahead and flex again. We're going to hold right there. And so the bicep's going to be the bulk of all of this structure. Go ahead and let it relax. But then as you come off of the supracondylar ridge, you're going to feel a little bit more of a ropier muscle. And you can feel the bifurcation here. So here is brachialis. Then anterior to that is biceps.
we identify the deltoid tubercle, partly because we're going to use that a little bit later to needle into the distal fibers of Coraco Brachialis. So at this point, there's a whole lot more surface anatomy we need to get to, but for our needling session for lab number 1, these are the structures you need to identify.
So we'll look at our treatment first for the deltoid in this introductory piece. We're just going to look at the posterior deltoid, but what we do on the posterior delt can definitely be done on middle or the lateral and the anterior. We have 2 different approaches. We can take a threading approach through the deltoid or a direct approach guided down toward the humerus.
Posterior deltoid, your patient's going to be in the prone position. Your knee length is going to be 30 to 40 millimeters, and your backdrop is going to be none unless you're using a direct approach. So we'll grasp the medial aspect of the posterior deltoid with the thumb, and the middle deltoid anteriorly with your fingers used as a backdrop. We'll direct the needle threading through the posterior deltoid laterally towards your fingers as a backdrop to determine depth and needle angulation. As an alternate method, the posterior deltoid can be needled directly with the humerus as a backdrop.
Then here's a more direct method. And here, I'm getting a little bit more anterior here, lateral to the middle fiber. So I'm probably getting a little bit of the middle deltoid as well as the posterior in that direct approach. But for simplicity of viewing, that's the way we did that. Okay, for infraspinatus, we're basically going to find our spine of the scapula, and we're going to drop 1 finger breadth distal to that spine to needle into the infraspinous fossa to needle or treat the infraspinatus. The deltoid there is faded, but you can tell in that midpoint. We're also going to get some of the posterior delt as well, even though it's further posterior in that tissue.
The infraspinatus, the patient's going to be in the prone position. Needle length here is going to be 30 to 40 millimeters, and the backdrop is going to be the dorsal surface of the scapula. We're going to palpate for the midpoint of the spine of the scapula. Then we're going to feel for the inferior drop-off. We're going to needle 1 finger breadth inferior and a posterior to anterior angulation perpendicular toward the inferior dorsal surface of the scapula.
Okay, for Teres Major, we're going to find a midpoint, or a little bit less than midpoint, between the inferior angle of the scapula and then the lateral aspect of the humerus. And we're basically just going to get into that muscle. Again, they're in the prone position. We're gonna distinguish the scapula from the rib cage, and then we're going to, at that midpoint, needle using our fingers as a potential backdrop.
For the Teres Major, patient again is going to be in the prone position. Needle length will be about 30 millimeters. And here there is no backdrop. We're going to grasp the muscle between the fingers and the thumb, palpating for the thickest part of the muscle, making sure to identify the lateral scapular border and the ribs. Using your fingers as a backdrop, we're going to advance the needle through the muscle until you feel the needle approximating your fingers in the axillary side. Caution here regarding the lung field, that needle angulation will be slightly lateral.
And normally I would treat this on the same side for camera view so that you can see better. I'm treating it from the other side, but I always would treat this on the side of the problem. Now, as you can see, this is very similar to what we did with the lats. So odds are, if you're treating lats, you're also getting some Teres Major, even more so whenever we treat Teres Minor next. Teres Minor is going to be a similar approach, but we're going to be a little bit more proximal to the shoulder. As you can see here, we're going to catch some lats, we're going to catch some deltoid, as well as Teres Minor.
For the Teres Minor, patient again is in the prone position, needle length approximately 30 millimeters, and there is no backdrop. Again, we're going to grasp the muscle between the fingers and the thumb, palpating for the thickest part of the muscle, making sure that we identify the lateral scapular border and the ribs. Using your fingers as a backdrop, we're going to advance the needle through the muscle until you feel the needle approximating your fingers on the axillary side. Caution again regarding the lung field.
So biggest difference here in Teres Major for the minor, we have to get a lot further into the axillary recess with our hand to assure that backdrop. And you're palpating for the lateral border of the scapula and just advancing that needle into that. Again, getting some deltoid, getting some latissimus, all at the same time. Then finally down to the upper arm. Here we'll look at the Coraco Brachialis, the Biceps Brachii, the Brachialis, the Triceps Brachii, and the Brachioradialis. I include the Brachioradialis because it's a good landmark as we're dealing with differentiating bicep and brachialis. But it's really more of an elbow muscle, but I included it here because we're looking at it anyway. So we'll look at our 3D anatomy for coraco, for biceps, for brachialis, and for triceps, and brachioradialis. So let's come here. And let me bring it up.
And then let's look at the three-dimensional anatomy of the upper arm. Here we'll look at the Coraco Brachialis, the Biceps Brachii, both the short and the long head. We'll look at Brachialis, and then we'll look at Brachioradialis. So let's start actually with Biceps Brachii, then we'll remove it to look at Coraco Brachialis. So Biceps Brachii, both the short and the long head. Let's look at the short head first. The origin is the apex of the coracoid process of the scapula. So we have three distinct structures attaching onto the coracoid, both the short head of the biceps, then the Coraco Brachialis, and then pec minor has an attachment on the medial surface of that coracoid process. It inserts into the radial tuberosity and the endobrachial fascia. So as we rotate down, we can see that coming. Let me go ahead and highlight the tendon itself, and that's its attachment there on that medial aspect of the radius. We come more proximally and look at the long head. So with the long head, the origin is the supraglenoid tubercle. I would have to let me remove some structures here that are in our way. so that we can see the path of the long head. All right. So as the long head comes, we're going to find it traveling all the way to the supraglenoid tubercle of the scapula. We'll take a look posterior or a medial to lateral view of that, so we can see that as it's coming up and attaching on that tubercle. Clinical relevance, if they have a superior glenoid tear, frequently that's why we're not doing any resisted bicep to prevent any further tearing, or if there's say a slap repair, that's why we avoid that resisted elbow flexion. Its insertion again into the radial tuberosity. Its action is it supinates the forearm, flexes the forearm, the elbow joint, and it's most effectively when the forearm is supinated. So let's take that. I'm gonna hide now the bicep so we can get a look at Coraco Brachialis. And so the Coraco Brachialis, again, its origin is onto the coracoid process of the scapula. It inserts, so we can look from a medial to lateral view, it inserts into the middle third of the medial aspect of the humerus, and its action is adduction and flexing the arm at the glenohumeral joint. We move further distally, and then we will find brachialis. Its origin is the anterior aspect of the distal half of the humerus, and so I'm going to bring deltoid back in. It's a nice landmark. Deltoid, right. So we look at the location of the deltoid as it attaches onto the deltoid tubercle. Just inferior to that is origin of brachialis. It inserts into the coronoid process and the tuberosity of the ulna. So whereas the biceps attaches onto the radius in this area, brachialis then comes down onto the ulna instead, but in a very close proximity to each other. Its action is flexing the arm at the elbow joint. And then finally, I include in this segment, because frequently if we're dealing with lateral issues, the brachioradialis actually comes up with its origin fairly high on above the elbow. So its origin is the superior 2/3 of the lateral supracondylar ridge of the humerus. So as you can see, its footprint comes up fairly high. It inserts into the lateral aspect of the distal part of the radius, so it travels quite a distance before it comes to attach. Its action is flexes at the elbow joint. It flexes the forearm, and so a powerful movement there. And that would comprise our three-dimensional anatomy of the upper arm.
So let's just look a little bit at some of our surface anatomy. We really covered this previously, but in the picture there on the left, you can see the landmarks for deltoid pec major, the tricep, finding these areas of the deltoid tubercle, providing just a little resistance can really help break out these muscles. On the posterior side, you might be able to identify the bifurcation of the triceps and be able to follow it all the way down to its attachment. Identifying or making the differentiation between brachialis and the biceps on the medial aspect. There's the medial epicondyle further distally. That can be very tender because of the neurovascular bundle running through that medial aspect right there.
So let's move on to our upper arm treatment. I will have 1, 2, 3, 4, 5 different treatment locations, very, very similar in location. If you want to treat these in a rapid fashion, we're going to treat coraco distally for the purposes of this introductory dry needling session because of its safety approach. Later we'll treat in the advanced portion, we'll treat the coracoid as well off of the coracoid process, but for now we'll treat it distally. Coraco Brachialis, we're going to find that deltoid tubercle. We're going to move 2 finger breadths more cranially, and then we're going to arc our needle lateral to medial over the anterior surface of the humerus to land into the muscle of the coraco brachialis. In this position, the patient has to be in the anatomical position so that the humerus isn't rotated internally. So that will be how we get to there.
For the coraco brachialis, the patient's going to be in the supine position. Needle length here is going to be 30 to 40 millimeters, and there is no backdrop. We're going to look at 2 approaches. First, from a lateral aspect, we're going to palpate for the deltoid tuberosity. We're going to grasp just superiorly to the tuberosity with the fingers, palpating for the brachial artery and thumb at the tubercle. From 2 finger breadths superior to the tubercle, we're going to needle from lateral to medial, just anterior to the humerus until you feel the needle approximating your fingers. Your patient arm must remain in the anatomical position to penetrate the coraco brachialis, and this is done to avoid the neurovascular structures up higher. Alternatively, the muscle can be needled in an AP direction, 1 finger breadth caudal from the coracoid process, 3 centimeters of depth, with a slightly superior trajectory to avoid the brachial plexus, brachial artery, and vein.
And then here's the direct approach, right off the coracoid process, just 1 finger breadth distal, slightly superior to avoid the brachial plexus and the neurovascular bundle there. For the introductory piece, I encourage you to stay away from this one that's a little bit more complex as a needle, and there's more potential for hitting important structures that we don't want to hit. So for introductory piece, let's stay at that lateral piece just proximal to the deltoid tubercle. Okay, for biceps brachii, here we're just going to grab this thing mid-belly. We're going to pull the muscle away from the humerus and needle from lateral to medial. Using fingers as a backdrop to determine appropriate depth. So with biceps, with brachialis, with triceps, the needling that you're doing here is done so that you can distinguish the results you get from needling bicep and brachialis. In truth, in clinical application, I may go more anterior to posterior to needle into both muscles at the same time, but I like to have the ability to separate the 2 out if I'm using it as a diagnostic approach to find out what exactly is giving me my business.
For the biceps brachii, the short and long heads, the patient again is going to be in the supine position. Needle length will be approximately 30 millimeters. There's not going to be a backdrop in this technique. We're going to grasp the biceps in the mid-belly, pulling it away from the humerus. We're going to needle from a lateral to medial, anterior to the humerus, using the fingers as a backdrop to determine appropriate needle depth. In this case, I would normally needle on this side. Because I'm over here, my finger placement will be reversed. Okay, and then on to brachialis. We discussed finding the space between supracondylar ridge and the bicep, and in there is going to lie that more ropey brachialis.
For the brachialis, the position is going to again be in the supine. Needle length will be about 30 millimeters, and the backdrop here will be the anterior aspect of the humerus. From the lateral aspect of the mid-humerus, we're going to push the bicep medially. In my case, I'm going to pull it medially to expose the lateral portion of the brachialis, which will be a ropey type of muscle that you'll palpate there. We're going to needle from lateral to medial into the muscle using the anterior aspect of the humerus as a backdrop.
And then the triceps. We're going to similar grasp the triceps distal, proximal to the olecranon, further distal in the muscle belly. I do this so that we can catch the short head of the tricep as well. If I'm treating it clinically, I may come up more into the bulk of the muscle belly itself and needle posterior to anterior, because I want to, in this case, address all three pieces of the muscle. We're going to do it a little bit more distally in the distal third of the forearm.
For the triceps brachii, the patient again is going to be in the supine position. Needle length will be 30 millimeters, and there's no backdrop. We're going to grasp the triceps muscle proximal to the olecranon in the distal third of the forearm. We're going to pull it away from the humerus. We're going to palpate for the medial neurovascular bundle so that we can make sure that we stay posterior to that. We're going to needle in a lateral to medial angulation with a slight posterior bias. We're going to use the fingers to assess for needle depth and direction away from the neurovascular bundle.
And lastly, the brachioradialis.
For the brachioradialis, patient again in the supine position, needle length approximately 30 millimeters. The backdrop here is going to be the radius. We're going to identify the brachioradialis by resisting elbow flexion. In the anatomical position, we're going to insert the needle 3 finger breadths distal from the cubital crease, anterior and lateral, posterior to medial, with a 30-degree angulation with the radius as a backdrop. If you'll hold right there. Right there. Perfect. And let it relax.
You can use your splayed fingers to bracket that muscle, then advance the needle down to your backdrop. All right, very good. So that concludes everything that we're going to look at for Module 3 as far as all of our anatomy, three-dimensional surface anatomy, all of our needle locations, and demonstration. And up next is going to be module number 4. Here we're going to look at the forearm, the upper and the lower leg, and then our tendons and ligaments. Concluding module number 4 concludes all of the introductory material that we will look for. If you are moving on to gain certification
then you would want to go to the first of the labs, which is an 8-hour lab, to then practice and demonstrate proficiency with these kneeling locations. So for our post-module assignment, for module number 3, number 1, what is the superior-most insertion of the Longissimus? Number 2, what spinal levels innervate Gluteus Maximus? Number 3, what are the 2 bony landmarks which are used to determine the medial-most location of piriformis? 4, name 3 muscles that attach to the coracoid process. And number 5, the inferior angle of the scapula is at the level of the spinous process of what vertebra? So if you're completing the module, answer those questions, place them in our Facebook, our dry needling arena, and we'll see you again in a couple of weeks for the next lecture or for the first lab.